Thank you. Thank you all for that introduction. We're going to open it up for question and answers and further discussion, open up to you all. I'd like to begin just by pick up on Denise's theme of politics and sort of all politics is local. How do we, as a culture, how do we use the lessons of Dale's book to begin to understand more clearly the diverse needs of our population? We're very insulated economically, socially. How do we begin to break some of those barriers down, both here at the local level, and are there lessons from Dale's story that we might apply to breaking those barriers down, understanding better what the needs of our community are?
I'll start with that. I think some of the answers lie in working at a grassroots level. I think that if we want to affect change, not just to affect the change on a global, we would love to do it on a global basis, or an international basis, or in our country, or in our state, or even in our city of Kalamazoo. But I think really in order to motivate people to take part in participating in that change, it has to be one-on-one. And I think that's Dale's efforts of building a clinic. We're really reaching out to a really small chunk of the population and Burundi. Expand it certainly, but I think that's the place to start.
You know, one thing that after I read the book, I said, what is new? What really caught my attention? Because I read tons of books about Africa and medical. So, you know what? And I'm going to relate that to what's going on like today in our state. One of the things is, of course, some things are random. He was lucky enough to meet 2 or 3 people that helped him. But it's very interesting, he was able to survive what he went through in Africa was horrible, but then to survive what he went through in New York was how many? Now, he was surrounded by people who didn't survive. Americans who did not survive, who are still in the same place. What made him different than the others? And what I observed, and I have seen it here too, is that he already had an advantage over even the poorest people in America. And that was he had, as you can see in the book, he had a good family, he had a good supportive family. It was functional, a father figure. He had gone to school. It doesn't matter, you come here and they send you to first grade, but he already had a formation that allowed him to survive here. When we have here children that do not have that stable family, where they have not had any education, he was able to read and go to the libraries because he was already motivated. This doesn't happen with the same people that were sleeping in the same parks. So what we have to see is that here in our country, we have men and women that will not have the same luck because they don't have the same chances when we begin. And if we keep cutting I heard someone call education for the infants and how important it is development in the first years of life. And when we call that babysitting, and we don't want to pay even a minimum wage for that, we don't value our children. I'm going to just say one last thing. When I was looking at numbers, the one that froze me was this. When it comes to infant mortality, the United States and Mexico have the highest rate of infant mortality for abuse in the world. Abused children here die at a higher rate than any other place in the world, considering poverty or not poverty. So if we don't look at that when we decide our policies, I don't know what we can do.
I agree with Carmen, and I think another element that is very different for our country that we interact with on a daily basis at our center is just not only the education component, because I think we have a responsibility to educate ourselves. In order for you to understand what is taking place once again, within your own community as well as globally, you have to have a sense of urgency and reach out and take the initiative to learn about it. Many of us, because we have trained and we've obtained education, we can live a comfortable life. And so it is very, very easy to be insulated from it. And we're not necessarily saying that's a bad thing, but then you also are sheltered from understanding what's really happening around you, within, not only globally, but within your own community. People are shocked when I tell them that 30,000 people do not have insurance right here in Kalamazoo, do not have access to basic health care. And so I think initially taking that initiative to educate yourself and understand. And then that will give you the ability to move forward as you begin to advocate, get involved. You know, actually I will be in, and I don't want to, you know, state a political platform, but just so that you understand from a very basic level. On behalf of the center, I'm in Washington next week, and we'll actually be trying to work with Congress and work with our representatives. One of the #1 things on the chopping block is health care for the very poor. It's, you know, $2.3 billion. That's the first thing that here in America that we're looking to cut out. Now, there's other things, and we have to understand the whole picture, and I'm not here to make a political pitch, because we do have to balance the budget, and there are a lot of important things. But for us in our country, for the #1 thing to be the #1 chopping block, so to speak, to be basic health care for the poor and the vulnerable, I think that sends a clear message. But the other point is, here in America, there's a fundamental belief that health care is a privilege. And that's very different from other countries. Other countries view basic health care, now we're not talking about elective surgery and all of those things, but just access to basic health care, immunizations, you know, checkups, medication, etc. In our country, there's a fundamental belief that it's a privilege as opposed to a right. And so that's something that I think we'll be toying with as we continue out within the political realms. But, you know, once again, back to educating, making sure that you know about it and that you're aware of the issues, whether they're affecting you or not, and then being able to move forward.
One of the big issues that I see as a physician here in the States and then going overseas is somehow the money is there, I believe, for better quality health care here and overseas. The redistribution has to happen somehow. I mean, when you look at the costs of medical care here in the States, many people or their insurance companies are paying these exorbitant costs for. My daughter had an MRI just of her knee a year or two ago, $1,500. And between us and the insurance companies and whatnot, you come up with that money. Well, $1,500 can go a long way. Family health clinic, preventive things, community outreach and whatnot. We're just spending huge sums of money, sort of foolishly, I think, for new radiology instruments, robotic surgery, several $1 million for one instrument. So there's a real disparity here between the haves and the have-nots. And it's the same overseas. In some of the, in Nairobi, Kenya, for example, a couple of the nice hospitals there in town are beautiful. They're as nice as any hospital that you're going to see here in a developed country. But the vast majority of people don't have access to that care, and they're left with small little clinics out in the rural setting, and they can't even get pap smears. Most women in Kenya never had a pap smear in their entire life. But at these couple hospitals, they're spending huge sums of money. So it's the haves and the have-nots that's an issue over there as well as here.
We have about 30 minutes remaining. I'd like to open it up to you all and see if you have questions or comments of the group. Yes, sir.
Yes. Excuse me. I've heard and read of the so-called barefoot doctors in certain places. Apparently, it sounds as though they're the first line that sees someone medically And then if they can't deal with it, it's up the line and each way up. And supposedly Cuba and China have used that, is my understanding. Does that reduce the cost of medical care, and is it effective?
I can answer a little bit. I don't know exactly the meaning, but what I can tell you with the numbers is that the case of Cuba, for example, something is very effective because Cuba has a 5 infant mortality rate versus 6.3 we have, and they spend $363 per capita per person in health, while we spend $6,714. So something that system may work a little bit better, I guess, just by the numbers.
The barefoot doctor concept was developed in China initially, and there's lots of programs that have looked at that model, and as a matter of fact, the program that I worked with was really modeled after that. It's get people access to care. So I don't know if there's any studies done to look at the cost effectiveness of it, but I do know that it improves the access to care. And so in the case of the refugee camps, they had no other access except on Thursday afternoons when there wasn't a government doctor would come in. But in the meantime, if they had a cut that needed suturing, there was the nearest place to go have it done was 3.5 hours away. So you had to train to do suturing then in the community. So yes, it improved access wonderfully. Great.
And I think, from my experience, I've worked in a clinic in some remote areas of Ukraine. That kind of care is absolutely necessary and effective. The diseases, the things that people are suffering from in many countries are very similar to what we are. And if you can see these patients early, diagnose their hypertension early on, and get them on one drug, or diagnose their diabetes with a couple easy lab tests, start treating them at that barefoot doc level, it improves quality of life, length of life, and it's a great model in many respects.
I was looking, there's hands up right here.
Just one additional point. If you've read Mountains Beyond Mountains, Tracy Kidder's book about Haiti, you know that he advocates very strongly for community health workers and believes, as Bill just said, that those individuals can make a tremendous difference in the health of a local community, because there's a handful of conditions that many people have that can be treated adequately by community health workers. The other side is prevention. A huge need and a huge call for preventive health care by community health workers, not physicians, who can provide preventive care, nutrition, good water. Those things are so critical